Namaste Betiya, Hamisha Khush Raho Betiya. A very good morning to you all. Myself, JVN Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine, and Faculty of Homeopathic Science at JAYOTI VIDYAPEETH Women's University, Jaipur. In this series of lectures, we are discussing about the diseases of the hepatobiliary system. In the last lecture, we have discussed about cirrhosis of liver, and before that, we have discussed about the acute and chronic liver failure. Today, we are going to continue in the series of the previous lectures. And today we are going to discuss about a very important topic that is known as portal hypertension. You get a lot of questions on portal hypertension many times in the examination, many times in short note, many times in the full question. And also this is a very important topic because it is seen not only with the hepatobiliary system, but it is also responsible for the different type of diseases that are related to the other systems as well. So today we are going to discuss about portal hypertension. What is portal hypertension? What is the etiopathogenesis? What are the clinical features? How to investigate a case of portal hypertension and how to manage it. So all these things will be covered today in a very brief way, in a very short way. So let's start with the portal hypertension. So what is portal hypertension? Portal hypertension, it is defined as the elevation of the hepatic venous pressure. So what is happening in the portal hypertension? There is rise or increase in the hepatic venous pressure gradient, that is known as HVPG, to greater than 5 millimeter of mercury, or the portal venous pressure above 7 mm of Hg. So what is happening in the portal hypertension? There is an elevation of the hepatic venous pressure gradient to greater than 5 millimeter of mercury, or the portal venous pressure gradient more than 7 millimeter of mercury. The pH cause portal hypertension. It is caused by the combination of two simultaneously occurring hemodynamic processes. So in case of portal hypertension, there are two hemodynamic processes that are going place simultaneously. Number one, there will be increased intrahepatic resistance. So there will be increased intrahepatic resistance to the passage of blood flow through the liver due to the cirrhosis and regenerative nodules. So we will have increased intrahepatic resistance to the passage of blood flow through the liver due to the cirrhosis and regenerative nodules. So in the portal hypertension, there will be increased intrahepatic resistance. So there will be intrahepatic resistance to the flow of blood that is flowing through the liver. And why it is occurring? Because of the cirrhosis and regenerative nodules. So cirrhosis we have discussed in the last lecture only. In the cirrhosis, we are getting fibrosis with the nodule formation. So there is fibrosis of the liver that is causing increased intrahepatic resistance to the blood flow, and there are also development of nodules. We have discussed two types of nodules in the liver cirrhosis. One is macronodules and one is the macronodules. Now there is increased splanchnic blood flow that is secondary to the vasodilatation. So because of this increased resistance, there is increased splanchnic blood flow, and it is developing secondary to the vasodilatation within the splanchnic vascular blood. So what is happening in this condition is there is increased splanchnic blood flow, and it is secondary to the vasodilatation within the splanchnic vascular bed. Now, what are the different causes of portal hypertension? The portal hypertension can be caused due to multiple causes. There can be prehepatic cause, there can be intrahepatic cause, there can be pre-sinusoidal cause, sinusoidal cause, post-sinusoidal cause, and post-hepatic causes. So there are multiple causes that are responsible for development of the portal hypertension. So we have prehepatic, intrahepatic, pre-sinusoidal, sinusoidal, post-sinusoidal, post-hepatic. So majorly speaking, we have three types: prehepatic, intrahepatic, and posthepatic. In the intrahepatic, we have three things: pre-sinusoidal, sinusoidal, sinusoidal, and the post-sinusoidal. So in this way, causes are divided into three parts: prehepatic, hepatic, posthepatic. Intrahepatic or the hepatic is again divided into three parts: pre-sinusoidal, sinusoidal, and the post-sinusoidal. So in the prehepatic causes for portal hypertension, these causes are affecting the portal venous system. So these are affecting the portal venous system before it enters the liver. So before entering the blood into the liver, the causes that are responsible for the portal hypertension are known as prehepatic causes. This includes portal vein thrombosis and splenic vein thrombosis. So if there is any kind of obstruction or the thrombus formation, then it will lead to the development of the prehepatic causes. So here we have these are the causes that are affecting the portal venous system before the sinusoids are entering the liver. That is known as portal vein thrombosis or splenic vein thrombosis. So there can be thrombus in the portal vein or the splenic vein. These causes are known as the prehepatic. Second is the intrahepatic. Intrahepatic causes are associated with the cirrhosis of the liver. Intrahepatic is divided into three parts: pre-sinusoidal, sinusoidal, and post-sinusoidal. In the pre-sinusoidal, we have congenital hepatic fibrosis. So there is congenital hepatic fibrosis with schistosomiasis. Sinusoidal causes includes the cirrhosis of the liver, and there are post-sinusoidal causes that includes veno-occlusive disease. So in the pre-sinusoidal, we have congenital hepatic fibrosis, schistosomiasis. In the sinusoidal causes, we have cirrhosis of the liver, and in the post-sinusoidal causes, we have veno-occlusive diseases. The third variety is the post-hepatic causes, that is affecting after the liver, when the blood is going across the liver. These are affecting the hepatic veins and venous drainage to the heart. So if the hepatic veins are affected or the venous drainage to the heart is affected, then it is the causes are known as the post-hepatic cause that are responsible for development of portal hypertension. This includes Budd-Chiari syndrome. So these are the different causes for portal hypertension. I have also given the picture in the e-notes related to the portal hypertension and the different venous blood flow in the abdomen. Now, what is the pathophysiology? The pathophysiology that is responsible for development of portal hypertension. What are the different changes that are going place in case of liver? This we are going to discuss now. Now, portal hypertension is due to the increased portal vascular resistance. This we have just now discussed, that there is increased portal vasculature resistance that is leading to the gradual reduction of the blood flow. So because of the increased portal vascular resistance, there is gradual reduction of the blood flow in the liver, and there is simultaneous development of the collateral vessels. So what is happening in this condition is there is increased portal venous resistance, vascular resistance. This is leading to the reduced reduction of the blood flow to the liver and development of the collateral vessels. So because of the reduced blood flow, collateral vessels are developing in order to supply blood to the distant part of the body. The photosystemic shunting occurs especially in distal esophagus. So the most commonly collaterals are seen as the photosystemic shunting. So there is development of photosystemic shunting, and it is seen especially in the distal esophagus. You can see this in the stomach and the rectum and anterior abdominal wall. So photosystemic shunting is often observed in the distal esophagus. We have stomach, rectum, and the anterior abdominal wall, where we can see photosystemic shunting. There is development of the collateral vessels. Collateral development vessel formation leads to more than half of the portal blood to flow through the systemic circulation. So what is happening due to this photosystemic shunting or the development of the collaterals? The blood is getting bypassed. There is collateral vessel formation leads to more than half of the blood, the portal blood, that is flowing through the systemic circulation. There is increased portal flow that contributes to the portal hypertension. So there is collateral vessel formation that is leading to the more than half of the portal blood to flow through the systemic circulation, and there is increased portal flow that contributes to the portal hypertension. Now, what are the clinical features that you are going to see in case of portal hypertension? So whenever a patient of portal hypertension is coming to us, what are the clinical features that we are going to observe in such a patient? There are three primary complications of portal hypertension. So we are going to observe following things. You can see gastroesophageal varices that is present with the upper GI bleeding. There can be ascites or hypersplenism with the reduction of platelets and WBCs. So in the portal hypertension, we are going to see three primary complications with the portal hypertension. We are going to observe gastroesophageal varices that are presented with the GI bleeding. There can be ascites. Ascites we have already discussed previously. And the third condition is the hypersplenism. Hypersplenism, that is reduction in the platelets and the WBC cells. So we are going to see three different types of complications in portal hypertension. One is the gastroesophageal varices. that is present with the upper GI breathing. There is ascites, and the third is the hypersplenism, when there is reduction of the platelets and WBCs. Now, how to diagnose a case of portal hypertension? Whenever a case of portal hypertension is coming to us, how can we diagnose this particular disease condition? The diagnosis is often made on the clinical ground. So whenever a patient is coming to us, the diagnosis is done on the clinical ground based on the presenting symptoms. There is portal venous pressure measurement. So we can measure the portal venous pressure of the patient. Endoscopy can be done to look for the esophageal varices. Abdominal imaging can be done, which includes ultrasonography, computerized tomography, MRI, and in the demonstrating a nodular liver and intra-abdominal collateral circulations. We can also check for thrombocytopenia, that is very common, and there are platelet counts that are usually reduced. The patient also complains of anemia that is attributed directly to the hypersplenism. So for the diagnosis is made on the clinical grounds. We have portal venous pressure measurement. There is endoscopy to look for esophageal varices. Abdominal imaging can be done in ultrasonography with computerized tomography or MRI in the demonstrating anodular liver formation and intra-abdominal collateral circulation. We can also check for thrombocytopenia, that is very common. There are platelet counts that are usually reduced, and anemia, it is contributing to the hypersplenism. Now, how to manage a case of portal hypertension? Whenever a case of portal hypertension is coming to us, how can we manage such case? So first of all, we have to manage for the variceal bleeding. Variceal bleeding can be managed by doing two things. One is primary prophylaxis. By primary prophylaxis, we can give propranolol, nadolol, or to reduce the portal venous pressure. Second is the prevention of the rebleeding. So if there is rebleeding, then we can give beta blockers, endoscopic variceal ligation. Ascites, the management of ascites, we have already discussed with the topic of ascites. So there is no need to discuss it again here. Hypersplenism can requires no specific treatment, and in severe cases, splenectomy under special circumstances can be done. So in the management of portal hypertension, we have to manage the variceal bleeding. We have to check for the primary prophylaxis that includes propranolol, nadolol, or to reduce the portal venous pressure. Prevention of the rebleeding is done by beta blockers, endoscopic variceal ligation. Ascites can be managed as discussed earlier, and hypersplenism require no special treatment, and you can go for splenectomy under special circumstances. So this was all about portal hypertension. In the next lecture, we will be discussing about hepatitis. There are different types of hepatitis that we are going to discuss. But in this series of lectures, we will be concerned only about the viral hepatitis. So this was all about portal hypertension. So in the liver, we have discussed acute and chronic liver failure. We have discussed about cirrhosis of liver. Today, we have discussed about the portal hypertension. In the previous lectures, we have also discussed about the ascites and more topics. So now it's your homework to go through all these topics that are given on the portal, and you also have to prepare the homeopathic therapeutics for all such disease condition. So in your homework, you have to prepare the homeopathic therapeutics for all such session, and you have to show it to me for each and every disease that we have discussed till now. So this was all for today. This session is powered by Digital Version 2.0, JAYOTI VIDYAPEETH Women's University. I hope the session is clear to you. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. Thank you very much. Have a good day.